this session is going to be an interesting session. The debate concept is, it's a 50-year-old with a clear lens and who wants spectacle independence. And we are looking at the different alternatives which would appeal to a person at this age group to get rid of his glasses. So we have two stalwarts of our Indian ophthalmology, the young Dr. Anurag Mishra and Dr. Kamal Kapur, who are going to debate on this. And Anurag Mishra is a consultant, cataract, pediatric ophthalmology, squint and oculoplasty, name it, he seems to be doing it all, from the Card Vision Eye Hospital, Orissa. And his topic is going to be clear lens extraction with trifocal, the right approach. And Dr. Kamal Kapur, who is the director of the very dynamic group of hospitals, the Sharp Side group of hospitals based at Delhi, but which is spread out all over. His topic is going to be Presbyopic Phakic IOL could be the option. And moderating them and giving his expert view is going to be our expert panel, Dr. Jeevan Tithyar. So we would look forward to his thought process after the two have done their job. So Dr. Anurag, we go on with your thought about clear lens extraction for a 50-year-old. On to you.
Thank you so much, ma'am. Am I audible and is my screen visible at all?
Yes, yes. Thanks for chipping in early.
Thank you so much, ma'am. Good evening, ladies and gentlemen, and greetings and regards from the land of Lord Jagannath. And the motion that has been given to me, the 50-year-old presbyopic correction, a presbyopic patient who needs a correction, I think there is a little bit of incompleteness in this motion, and hence that's the reason why I've added on a few facets which have been clandestine in it. The 50-year-old patient who has come to me for presbyopic correction has, in all possibilities, come to me for diffraction and glass prescription and not for a surgical choice. The moment I introduce him to the surgical choices that are available with me, and the discussion that goes on after that is basically because of the fact that the patient is intrigued more than motivated. And the motivation that needs to be curved into the patient has to be really crafted in. It needs to be curated into the patient. But hang on, is this the patient who needs to be motivated? Well, we'll see that at the end of the 6 minutes duration of deliberation that I have on my side. This story is going to be depicted to you, ladies and gentlemen, in its 3 stages, just like any story. The first stage is the prologue or the preoperative considerations. The main text is the procedural considerations, and then comes the postoperative considerations, which forms the epilogue. This is between 2 procedures which hang in the balance. One deals with disturbing the intact structures in the eye. There is no cataract and we're removing the lens like that. And the other procedure invades the intact space. So let's talk about a few changes that happen in this intact structures which are age-related, and how do they affect this intact so-called space that is going to be invaded by the phakic IOL. Let's talk about the crystalline lens first. Studies show that with increasing age, the axial curvature of the anterior posterior diameter of the lens increases by 21%. This is one lens which is distant fixated of a young individual. The second picture is the near fixated lens of the same young individual. And the picture down below is the aged lens, which is distant fixated. So the anterior posterior diameter of the aging lens is even more, which is when it is distant fixated, than a young lens, which is near fixated with full accommodation in question. The result, the space with which the phakic IOL is being utilized is going to be reduced. So it has more likelihood of brushing against or touching physically the lens and the iris both. There is a light scattering that happens in the aging lens, even without the presence of cataract. And the scattering happens most commonly in the C3 cortical area. The C3 cortical area is the innermost cortical area, which is closer not only to the optical center of the lens, but also to the nodal points. This is without cataract. Add to that the scattering that is, or the reduced contrast that is likely to happen from a ring design of a phakic IOL, the patient's not going to have a very clear or crisp vision. The anterior chamber angle with age reduces to the extent of 0.11 mm per year. Now, to prove this is a patient of mine who's 50 years old. Look at the angle dimensions at 500. ACA 500 measures at 27 and 22 degrees. 27 and 22. Remember the numbers. This is another patient who is young and has come to me for ICL. The dimensions in the angle are 38 and 53. before surgery. Post-operatively, the same patient's angle comes down by 10 degrees to 29 degrees. So 27 and 22 in a 50 years old, that angle, if reduces by 10 degrees after you put in the phakic IOL, you are counting an angle of 17 degrees. Big reason to worry. Accommodation. At the age of 50, it is said that the accommodation is really absent, but some of them are left with a 0.5 diopter. So it might be difficult for us to decide the add power that we are giving to the phakic IOL. And if there is a 0.5 diopters of accommodation left, eventually it wears off. Eventually, the patient also has disturbances in his near vision. The spherical aberration, while we implant an intraocular lens, all we have to negate is the corneal spherical aberration, which is around 0.2. But when we are judging the phakic IOL, the total spherical aberration of the total eye as a system has to be taken into consideration. And this negative spherical aberration in the phakic IOL is not enough to negate all that. So the crispness of the vision might not be there, although you might have a good depth of focus. When you consider a trifocal IOL, which of these factors to consider? Practically none. But when you consider a phakic IOL, and which of these preoperative factors to be considered? Well, all of them. Let's go to the procedure part. These are the two IOLs that are in question, the trifocal and the presbyopic correcting phakic IOL. The refractive index has a difference, 1.46 and 1.55. The basic reason is the phakic IOL is hydrophilic in nature. And in that range, we all know that one point decimal difference between the refractive index also plays an important role. The ring design they have created it has less number of rings from 5 to 9, so that's a good job. I'll give it to them. But let's talk about the only study that has been published in here. The pupil diameter reduces after ICL or phakic IOL, and it does not recover even after 3 months. With a trifocal IOL, it also reduces, but it recovers after 3 weeks to 3 months. The reason, the difference between the two is the phakic IOL actually has a mechanical factor for which the the pupil size reduces. So consider a patient driving under mesopic conditions, the pupil is small, the distant vision is going to be affected, which does not happen with a trifocal IOL because there's no mechanical factor. This is the only study that I could find of note where they have studied 8 patients, 16 eyes, and look at the results.
Doctor,
4 weeks after surgery.
You have 1 minute, yeah.
9 out of 16 eyes are emetropic. 9 out of 16. What happens to the rest 7? We don't know. The 40 years old produces a very decent depth of focus curve, but at 48 years old, look at the intermediate vision dropping significantly. This is another curve from the same study, 20/20 or better after bilateral implantation with a phakic IOL goes up to 60%. It goes up to 80% in case of trifocal IOLs. So after surgery, different studies have shown different incidence of cataract formation after phakic IOL, 9.6 to 5.2, but they all agree that it happens. Dr. Mandal also thinks that there is a significant risk of glaucoma following phakic IOL implantation, and some of them actually go on to develop refractory glaucoma. So the conjure of all these factors combined, presbyopic PCIOL is the best choice for this patient, particularly when the bar ranges are less than 6 or more than 30, or if the cylindrical dioptric requirement is more than 3 diopters, because trifocal lenses are not manufactured in that level. But the CLE is a better option if you respect the age-related changes in the structures, preempt the post-operative complications, do not grin at the prospect of multiple phases of earning coming from the same reserve, and do not readily accept based on an anecdotal, fragmentary, and headed evidence rather than scientific one. So, ladies and gentlemen, the motivation that we were talking about in the initial part of the discussion was actually not needed by the patient. It's actually needed by this guy, and who better to provide the same motivation and curate into him than the person who is considered a master in that subject. With that, I must rest and give it to the next speaker to curate that motivation into me. Waiting for your 6 minutes to be over, sir. Thank you.
Dr. Anurag, you are truly wonderful. And Dr. Kamal, you really need to do some magic.
I don't need to do magic. I am magic. So anyway, Anurag, I think it's good you showed the last picture with hands folded and bent down. So I guess that's actually stated that you do need some pumping up and some confidence in what you were saying. Anyway, see, the topic given to me is that phakic IOL also is an option. So I will stand by that. While I do not deny whatever Anurag has said, there are options where a refractive lens exchange definitely is an indication. but refractive lens exchange is the only option or other options cannot be considered, I would like to put my point forward here. So I would just say that, the simple ancient surgical wisdom, and I'm sure Anurag's teachers, professors taught him that do not sacrifice any tissue in any surgical procedure if it can be saved. If you can save a tissue, and if it adds advantage to save that tissue, I would rather do that. So in that particular case, in this particular case, is a human crystalline lens. Now, we have a huge track record of phakic lenses, I think probably highest in the country. And I would disagree with a lot of issues with Anurag probably, but I would excuse it because of his probably a lesser experience with this particular issue. Yes, I agree. You need to be very, very meticulous in your workup, but I'm sure he's very meticulous in his workup for his trifocal lenses also. And that too, if he's operating a clear lens at a 50-year-old man. But if he's rash and it doesn't want to do his angle kappas and his surface disorders and his maculopathies and corneal irregularities and measuring of astigmatism, well, sooner or later is looking for trouble, even if he's putting a trifocal IOL. So similar, but probably a little bit more meticulous workup would be required if I'm planning for a meticulous end result with a presbyopic phakic IOL. Now, you see, efficacy of phakic IOLs has been proven over a decade. The best point in favor of a phakic IOL in a particular set of patients is its reversibility. And I'm sure Anurag will agree with me. Whatever he does with a trifocal lens, he cannot reverse it. At the most, he can explant the lens and put in a monofocal. So the purpose is defeated. Whereas if you put in a phakic lens and by just far outreaching chance, the lens does misreact or the patient is not okay with it, I have the option of doing a reverse procedure. And there is a proven track record with this particular technology. Another thing I must admit is that the availability of high astigmatic phakic presbyopic lenses, and I've done till -5 astigmatism with presbyopic lenses, and my patients are doing fine. Now, where are the issues? There are some times when the patient myself may be having some accommodation. I am 55, and I'm sure anybody can vouch for it. Nobody's seen me wear glasses. And the best part is I'm an emmetropic. I'm hypermetropic in one eye, and I still have accommodation. And let me tell you, there are a lot of 50-year-old plus patients walking around who probably would have some accommodation. So when I go in and take out their crystalline lens, guess what? I'm taking out whatever little depth of focus they had. And then what am I putting? I'm putting a diffractive lens inside the eye. And I'm sure most of us, eyes closed, hearts closed, in closed rooms, talk about halos and glares. And halos and glares with less number of rings are definitely better. And also availability of eyeedu phakic lenses with ICL, the Viva series. I've not used any, but I'm getting very good results hearing from my friends. So that option is always available. But let's not forget, number one, I'm taking away whatever little depth of focus the patient has because of his natural lens. If the patient is high myope, I'm exposing him to the chances of retinal detachments. I'm putting in a lens which has got 13 to 15 rings. I'm exposing him to colored halos and glares, and we all admit that these lenses do cause that. And if there is some compensation, because there are some lenses, and I'm sure Dr. Naren would agree with me here, there have been papers published that the inherent crystalline lens a lot of time is offsetting the issues offered by the crystalline lens are taken care by the cornea, and the issues of the cornea are taken care by the crystalline lens by adaptation. So that figure also I'm taking away. And the worst is that the issues of a larger number of rings in a multifocal lens, and not to forget the dysphotopsias, which you may be including. And I can tell you, Anurag, once your patient starts having halos or dysphotopsias, you just have to cut a sorry figure. Well, with phakic lens, you don't have to do any one of these two. And another thing, even if God forbid there's an issue, I can still reverse this procedure. Minimal intraocular inflammations. The complications associated with the phakic lens, especially high myopes, let's say, very high myopes or high hypermetropes could be tricky. Now, what will happen can happen. So these are the kind of things which can happen if I do an intraocular surgery, removing a crystalline lens. You can have a capsular rupture. You could have endophthalmitis, PC, rand, bad rexes, decentration of lens, capsular fibrosis, decentration of your multifocal lens, accidental running off of your capsular rexes. All these things can happen. And the number of factors which can go wrong when I'm doing a phakic lens with a trifocal lens probably would be higher than what I would be doing the simple phakic lens, putting inside the eye, lifting, shutting it, locking it, and forgetting it. Now, endophthalmitis is a huge issue. Now, I'm just going fast. The endophthalmitis, younger patients, all these things we need to take care of. A 50-year-old man coming to me with, mild refractive issue. Yes, I may want to do a clearless extraction also, but there would be definite indications for me to do a phakic IOL, very high myope, patient not wishing to have his crystalline lens taken away. I just operated a lady 2 weeks ago, 2 ladies from the same family, daughter-in-laws from a big jeweler in Delhi. One opted for a clear lens extraction and the other one opted for presbyopic IPCL, and both were right. I did not dissuade anyone for them because both had a logic. One said, my lens is working fine, I don't want it out. The other one said, I would rather get it out because sooner or later, maybe 5-10 years, I'll get a cataract. So both are right. So I am not saying what Dr. Anurag said is wrong, but I am saying an IPCL or an ICL or a presbyopic IPCL or a phakic lens also is an option, and you should always have it in an armory, provided you are adept at doing that. And if you have systems and infrastructure in place to have good outcomes. And the best part I said was it's reversible. Thank you. I guess I did it in time and I didn't waste much time.
Yeah, thank you. Thank you very much, Dr. Kamal. That was wonderful too. Dr. Titiyal, we need to learn some pearls of wisdom from you now.
Thank you, Dr. Chitra and Dr. Ram for getting me into this very important topic or discussion or debate. I think both Anurag and Kamal had put their points, and both are absolutely correct in their point of view. Both type of surgeries, if patient is willing to undergo surgery, both phakic IOL as well as for a clear lens extraction, we do have a space for both option for patients. It is up to the us to decide what is suitable for a patient and patient's acceptance. We know that both surgeries will have its pros and cons. Let me start with the IPCL, which has been there for last 5-6 years in our practice. And I also seems to have some long studies on that experience with IPCL. The few important points we look into in these areas for people who are listening to us. Kamal, you can stop your,
okay, sir,
sharing
just a
the,
minute. Yeah, okay.
Yeah, thank you. So I think the important points are to be considered is few. One is age of the patient, because once you look for a younger age group, IPCL may be a better option sometimes because you have a clear lens which is functional. In that, we like to assess two important things. One is the sclerosis happening in the lens nucleus and its effect on the visual symptoms or visual quality-wise. We normally do all these patients two things. One is we look for internal aberrations. Second, we do a DLI in eye trace.
Yes.
If the DLI is less than 5, or if you have a higher internal order aberrations, it's HOA, then this candidate may be suitable for a clear lens extraction more clearly.
Absolutely.
And second, if these two things are all right, if the AC depths are quite good and pupillary diameter is as normal as Indian population, I might prefer to go for IPCL these lenses. It's not that IPCL will not have a visual symptoms, because these are again
Yes.
diffractive lenses. Sometimes they do have little bit of halo, the pupil is larger. And there we have to make sure the pupil is normally remains normal size. I normally don't dilate these cases subsequent to posterior period, because these lens tends to shift their position with the pupillary size sometimes. So little pupil dependence in terms of especially near distance, they don't really make a difference. Near makes a huge difference. If pupil constricts, the lens position changes, the near vision gets little distorted, but it settles down as the time passes. The bilateral implantation is quite acceptable. I have had few patients who have undergone cataract surgery subsequent to IPCL also, maybe after 1 or 2 years, because it seems that nuclear sclerosis advances quite rapidly in some cases in the high myopic patients in these group of patients. Cases where we have a difficult anatomy, anatomy, little bit of sclerosis, a patient has, little bit of difficulty in terms of the range of accommodation, because that's also very important. What is the reserve you're going to give to these patients? And that's why any patient between 45 to 55, both options are there. Patient beyond 55, I normally tend to go for clear lens extraction as such. I think both the points are well given. As far as complications are concerned, both are intraocular surgery. INDOF can happen to both the groups, but more chances there may be cataract surgery. Posterior segment assessment has to be perfect before and after surgery, especially more for a clear lens extension. But nowadays we can see so many things so clearly, the chances of increased detachment, other things are going to be less in all surgeries. But I've seen in all my patients where we do clear lens extraction, the PBD induction is much more. The floater incidence is much more with clear lens extraction as such.
So the angle metrics also is something that we should look at.
Anurag, your point is absolutely correct. If the angle is, you can't go for
Absolutely.
IPCL as such. And
Absolutely.
there we tend to go for a clear lens section. That is one of the major, I think, the recent trend for me also. Any patient with a little shallow chamber, and especially female patient, I go for a clear lens section in these patients.
So I'd just like to add one point, Dr. Chitra here. I think I agree 1000% with Dr. Tityal, and as I told Anurag, both options are open. And what he mentioned was a DLI. You know, I slipped my head. I'll share something as an anecdote. Samir came to me for doing a presbyopic IPCL for him because he was a myope. And I did a DLI. One eye was 6 on my eye trace, another was 4.5. I said, no, I will not do a phakic lens for you, Samir. I'll do a lens extraction. And he's very happy. So, you know, this is a very important point. For all of us who have access to eye trace, I think this is a beautiful tool for deciding which way the clock swings.
Yeah, DLI, and I think even the lens rise should be taken into account when we are looking at either of these choices. So, Dr. Ramurthy, what I wanted to ask you was, when it comes to these, between the two of them, would you also think of give a preference for a myope or a hyperope in a presbyopic phakic IOL? Is something any of you could answer. I mean, I just thought that DLI, higher order aberration, lens rise. But would we prefer a myope for a borderline situation, a myope we'll prefer, or a hyperope would prefer? Yes, Dr.
For a borderline myopes, you know, these people are very happy with their near vision because they can read without glasses as such. So these patients, you know, sometimes they are in the range where some multifocal may not be, you know, of choice because the axial length may be a little higher. So if you have a good anti-chamber dynamics, I might go for IPCL in those cases because they'll have a, you know, a near vision without glasses. Because myopes, they don't like to use access, glasses. But yes, if they have the range for a trifocal IOLs, both options are open there also.
So would you
Dr. Chitra, can I share a trick which I do? Can I share a trick here for the audience?
Yes.
Like suppose I have a moderate myope. So what I do is I correct their distance vision to emetropia. But in the non-dominant eye, I give them overcorrection in their presbyopic correction by 0.5. And as Dr. Tityal rightly said, they are super thrilled because they can probably get the object a little more. You know, a lot of my critics would say 0.5 does not make a difference. Believe me, I do it. It makes a difference to these patients.
What would be your add correction? Would it be +2 or 1.5?
+2, basic +2. Start with +2. Don't go for 1.5, 1.25. It will not work.
And Dr. Namrata or Dr. Ramurthy, would you believe that it should be definitely the patient should have had a PVD before we think of doing a high myope clear lens extraction?
Yeah, I mean, definitely you need a posterior with a complete PVD, if in case you're considering a clear lens extraction. But I would completely stay away from doing a clear lens extraction in high myopic patients. It might be for moderate myopic patients. Whatever, all chance of retinal detachment is supposed to be less, but still it's not a chance worth taking. I think it was a wonderful presentation by both of them and a great summary by Dr. Tityal, and there's not too much to add except for reiterating a couple of points. That cutoff age of 50 that's mentioned is exactly the cutoff for me, not that I have a hard and fast rule. Less than 50, generally I go for presbyopic phakic intraocular lens. When the patient is beyond 50, we go in for consider more clear lens extraction with a multifocal intraocular lens. The second point, of course, being the kind of refractive error that they have. Because many of these hyperopes, as Anurag very nicely pointed out, already have shallow anterior chambers, smaller eyes, and there is a greater crowding of anterior chamber once you put these phakic intraocular lens. So in these cases, I would tend more towards putting in a phakic intraocular lens. While in case of low myopes, maybe of course, as Tityal said, many of them don't need any correction at all. If at all, a moderate myope needs, nowadays there are patients, mothers of my smile patient who says, "What about me? Can you do something for me?" And she has a -3.5 or 4, and she is 53, 54 years old, and clearly lens is absolutely clear. Then we can consider putting in a presbyopic phakic intraocular lens. And I think all of them emphasized about the importance of DLI. Anything less than 5, I would also tend to go towards a clear lens extraction. And apart from the currently available presbyopic IPCLs, we recently were exposed to the EDOF ICL platform. And once that comes in, well, mind you, it's not just the number of rings, but both of them are diffractive lenses, whether it's a trifocal lens or whether it's a presbyopic IPCL. But I think the EDOF lenses are likely to be slightly better. Maybe the near vision is not, from whatever we heard about the presentation, near vision is not going to be as crisp as what you find with the trifocal presbyopic IPCL. But then they're going to take care of, like most EDOFs, they're going to take care of intermediate vision and to some extent a near vision. And most importantly, for those of you who might consider putting a presbyopic IPCL, the power comes right from basic power from 2 to 3.5. The whole problem is presbyopia is a dynamic process. What the patient requires at the age of 42 is what he or she may require at the age of 55. So basically, I place, whenever I'm using a presbyopic IPCL, I put in a +3 diopter lens in one eye and +2.5 in younger patients. A +3 gives you only +2 for near and +1.2 for intermediate. And that's the least these patients require. Going less than that may not really meet their needs. That's my just 2 cents about this.
Thank you very much. Thank you, Dr. Tityal, and thank you, Dr. Kamal. I knew you had your issues, and I would want Dr. Tityal to stay with us till his time, which he promised.
Thank you. Thank you, Dr. Chitra. Thank you, everybody.